Hi, welcome to the CJSN podcast. This is Chethan Puttarajappa from the University of Pittsburgh Medical Center. On behalf of my co-investigators, I am delighted to discuss our recently published article, A Markov Analysis of Screening for Late-Onset Cytomegalovirus Disease in Cytomegalovirus High-Risk Kidney Transplant Recipients. Cytomegalovirus infections in kidney transplant recipients increase morbidity, hospitalizations, and are associated with lower patient and graft survival. The patients most affected are patients with a negative CMV IgG status who receive a kidney from a CMV IgG positive donor. Prior to the routine use of antiviral prophylaxis, up to 2/3 of such high-risk recipients developed primary CMV infection. Currently, most centers administer 6 months of valganciclovir prophylaxis to prevent primary CMV infection. This has significantly reduced but not eliminated the incidence of primary CMV infections. Still, up to 30 to 40% of patients can develop CMV infections within the first year of transplantation after stopping prophylaxis. We previously reported that once-a-month screening for viremia after stopping prophylaxis could reduce CMV-related hospitalizations. There are 3 factors that make a screen and treat approach very appealing. 1. Most, if not all, CMV infections have an asymptomatic viremic phase. 2. CMV PCR is highly sensitive and specific to detect viremias. And 3. An effective and safe oral anti-CMV drug, valganciclovir, is available. We studied this screen and treat approach using a Markov decision analysis. Decision analysis allows for comparison of 2 or more strategies for a problem by quantifying the differences in costs and effectiveness. We created a Markov model that incorporated various CMV clinical states such as asymptomatic infection, infection managed as outpatient, and infection requiring hospitalization. We leveraged existing data on CMV replication and epidemiology of late-onset CMV infections. We compared 5 different strategies in the model: a strategy of no screening post-prophylaxis, or screening at intervals of 1, 2, 3, or 4 weeks for 6 months after stopping prophylaxis. So what did our model show? We found that both the costs and quality-adjusted life years increased incrementally as the frequency of screening increased. Screening weekly yielded the most quality-adjusted life years, but was also the most expensive. When willingness to pay thresholds were considered, screening every 2 weeks was the dominant strategy for willingness to pay range of $14,000 to $185,000 for saving 1 quality-adjusted life year. So what does this mean for clinical practice and future research? Our modeling strongly suggests that screening for cytomegalovirus viremia should be considered for all high-risk CMV kidney transplant recipients once they complete 6 months of valganciclovir prophylaxis. Of the available strategies, screening every 2 weeks appears to be the most reasonable approach. Our analysis suggests that the cost of screening is easily overcome by reducing the costs associated with hospitalizations and adverse outcomes from CMV infections. Further studies should report clinical findings with implementation of the above screening strategies. In conclusion, using modeling and decision analysis, we have shown that post-prophylaxis screening for CMV is a highly cost-effective way to reduce the morbidity and cost burden associated with late-onset cytomegalovirus infections. Thank you for listening to this CJSN podcast.
This podcast is copyrighted by the American Society of Nephrology, all rights reserved. All content in this podcast is for informational purposes only and is not intended to be medical advice. This podcast should not be used in a medical emergency or for the diagnosis or treatment of any medical condition. Please consult your doctor or other qualified healthcare provider if you have any questions about any medical condition or before taking any drug, changing your diet, or commencing or discontinuing any course of treatment. Thank you for listening to this podcast of the American Society of Nephrology.